So for example, lung, I think is a good example for that, right? We're gonna test for EGFR, and then there are medications that are gonna specifically target that mutation. 20 years ago, we weren't doing that. And so if you have a lung tumor with an EGFR mutation, that's very different than you have an adenocarcinoma. And I think that's another way that cytology is really very exciting because we've been on the forefront of that, right? How much information we can get out of such a teeny bit of material.
Welcome to the People of Pathology podcast. I'm Dennis Strang. On this podcast, we explore pathology, laboratory medicine, and forensic science. What traits lead someone to pathology and lab medicine? Curiosity is a big one. Also, the desire for knowledge, for lifelong learning. My guest today is Dr. Allison Goldberg. We're going to hear about her journey from surgery to pathology to cytopathology, and we'll get her thoughts on training fellows, AI, and how all these things satisfy her own desire for knowledge. All right, get ready to be inspired by Dr. Allison Goldberg. So I want to start all the way back at the beginning with you. Can you tell me about what was your inspiration for becoming a doctor?
Yeah. So I feel like I've answered this question a couple times. And for whatever reason, when thinking about it this time, I actually came up with some additional thoughts. The first thought is an easy one. So my father, as a chemist by training, worked in the pharmaceutical industry for much of his life and worked on AIDS medications in the late 80s, early 90s, which was incredibly inspiring as a kid to see, right? AIDS was obviously all in the news. People were dying, lack of government involvement. I could go on and on.
Mm-hmm.
And here's my dad, a chemist by training, to my eye, and I think in truth, making a genuine difference in the lives of thousands, millions potentially of people ultimately across the world. He wasn't an MD. He had worked towards his PhD, and then I arrived on the scene and that stopped that. But his chemistry degree ended up getting an MBA and leading projects, pharmaceutical projects through. That was inspiring to me, right? Here's my dad, who I really look up to. And who does he look up to? The MDs on the team. So throughout his work, he always spoke so highly. I wish I had gone to medical school, or if only I had gone to medical school. They're the ones making the real difference. So that was, I would say, inspiration one, was seeing what research could do to impact lives and hearing from a man I really admired. The people he admired, they had MD degrees. So I think that put in my mind very early on that if I wanted to make a difference, which I very much did, and loved science, which I very much did, MD was the way to have maximum impact. I think also looking back, and I'm not sure why this dawned on me this past weekend when going through these questions, but thinking about my pediatrician growing up, Dr. DeSanto, who was, right, I still remember his name, truly was like a pillar in our community where we grew up, right? Everybody knew him. If you saw him at the grocery store, it was like a celebrity sighting. He was also very much making an impact, and a huge impact, in people's lives and families' lives on a much more local level. And I think both of those influences, sort of the far away but global impact versus the very close, very local impact, was interesting to see that an MD degree could do either of those things, or occasionally probably both of those things over the course of a career. So I think those were the two early influences that made me think of a medical degree as a good opportunity.
Okay, those are both interesting stories, and I think, like you said, they kind of have the same theme, that of making an impact, helping other people, either in your own community or worldwide. And I think, as we're going to see, I think that kind of informs a lot of the things that you've been doing.
Thank you for saying, right? I think we all need to work so we can have food and shelter and all that. It's phenomenal if that work can be meaningful, makes it easier to get out of bed, right?
That's for sure. Yes.
Yeah, yeah.
All right. So then, going into medical school, like what sort of specialties then were you looking at?
So this is a long story.
Okay.
I'm not sure how much time your listeners have. So, right, started med school, absolutely loved everything, right? Day one, we do histology, we're at a microscope. I think this is just super cool. That histology class was taught by PhDs, and it in no way dawned on me that microscope work was also MD work, right? Going back a little bit to my dad, who all of the research he had done obviously included mouse model work, included monkey level work. So I saw all of that as the PhD research side incorrectly, but yet that's how I saw it. It didn't dawn on me to start to think about career options at that point. I just loved that I was learning, loved getting all this new information spoon fed to me, was incredibly happy the first 2 years of med school. Third year of med school, right? We go through rotations. At that point, I was thinking maybe women's health ish, but not based on much besides I was a woman, which is not a great, right? That would mean that half of us would have to go into women's health. It didn't really make sense. Just seemed available, seemed applicable. I'm not sure. Seemed like an area ripe for improvement, and I would have been excited to be part of that. Let's say that. Ended up really enjoying every rotation I did, right? OBGYN, internal medicine, surgery. I loved it all. I knew my personality, right? So I started thinking through, okay, what kind of a day do I enjoy? I knew I enjoy a day that's somewhat planned out. I don't like getting to work and not knowing what my day is going to be. Okay, so that rules out ER, that rules out trauma surgeon. It doesn't rule out much else. I also found, and I want to say I have so much respect for the people who can manage diabetes for somebody. That's a hugely important job. It wasn't satisfying to me in the same way. Seeing, over my internal medicine rotation, seeing the same patients regularly for slight adjustments of things, for better or worse, didn't satisfy me in the same way that, you had breast cancer, we did a mastectomy, and now you don't have breast cancer. And I recognize, of course, they still need treatment and there might not be a complete cure, but it felt so satisfying. And I also really found myself drawn to the operating room because I saw it in some ways as this quiet space to focus on one problem, solve this one problem as a team. And most surgeries end up being successful and check, right? We solved this problem as a team. I also just frankly very much enjoyed the aspect of cutting and sewing, which maybe sounds a little too basic, but I just genuinely enjoyed it. So I liked most things at that point, didn't think of pathology at all, totally didn't recognize it as a field, which is crazy. I was sending frozen sections. Who did I think was calling those back? Didn't think about it.
Mm.
And so I went into surgery. I was a surgery resident here at Jefferson, where I now work, for 3 clinical years, which were wonderful. If I'm being honest, throughout that time, there was this little noise in the back of my head saying, you're enjoying this, but not as much as you enjoyed it as a medical student. And you're missing parts of medical school that you loved. The questioning, the constant search for new information, the pushing the boundaries of your own knowledge. I was missing that. We all, in the surgery residency I was part of, go into the lab. I spent a year in the lab doing mostly mouse model work. I was thrilled. It was everything that I had wanted, right? I was using my hands to take care of mice and then sacrifice mice and then take care of their remove their tumors. So I was still using my hands, still getting to do the cutting part, still very much had that like checkboxy aspect, which for better or worse, I find very satisfying. But getting to ask questions, getting to really engage with the literature and try to push to gain new information, to learn new knowledge. And I felt in a lot of ways reawakened, as opposed to those first couple years of surgery where I felt like I was given a cookbook in some ways, memorize these 20 steps, and now you know how to remove an appendix. I was now being told, we've learned steps 1 through 5. We're working on step 6. We're thinking these could be options. What do you think? What experiments could we do to figure out what a best step 6 would be? I was thrilled. There's a personal aspect to this story also. I had a planned pregnancy of surprise twins while I was in the lab. They were born my very last day in the lab. So left the lab, went back to the operating room. 6 months later, for a variety of reasons, realized this was a great path for 3 years. But for me, for my family, for my changing priorities, things need to change. And at that point, I started asking pretty much any parent doctor who would talk to me, what is your life like? What works about it and what doesn't work about it? So that I could try to figure out what's next. Or is there a next? Is there just I need to get my personal things ducks in a row and then I'll go back to the operating room and that'll be a happy end to the story? Or is this a branch point where it's time to try something new? I spoke with folks and not even just in academic medicine. Spoke with folks in private practice, spoke with folks in industry, spoke with folks in government regulatory agencies, really anything you could do with an MD. If you were a parent and you were willing to give me 10 minutes, I was so excited to pick your brain. And will always be appreciative for all the people who gave me time and spoke with me. One of my surgeon mom friends, she had been a resident with me and then had moved on to faculty still where I was working, happened to know a pathologist mom. We all had kids around the same age. And the surgeon mom said, you should talk to this pathologist mom. She seems to have it figured out. And she and you have very similar personalities. I think if nothing else, it's worth a conversation. It was an incredible conversation. This woman doesn't work here anymore. I honestly am not sure if she knows just how important that conversation was in my life. But right, she spoke with me about what did her day look like and not when she got to work, because that is very much not the start of the day of anybody who has other people that they take care of in their lives, whether it's spouses, parents, friends, kids, whatever. What did her day look like at the actual start of her day? How was she balancing all the things that she loved? Did she still feel like she was doing meaningful work, right? I'd been gaining education for so many years at that point. I didn't want to lose the opportunities it afforded me. I didn't want to lose the education, right? I think with anything, if you're not using it, you're going to end up losing it. I very much wanted to still be taking advantage of that education, but in a way that fit for my life and my priorities now. After meeting with her and sort of hearing, gosh, what she's doing sounds inspiring, sounds important, sounds genuinely exciting, both on that day-to-day basis, that day-to-day grind, and that overarching long-term, what is she working towards? Both sounded exciting. And she still had space and even more importantly, the flexibility to do things outside of the hospital that she loved, which, right, I think my story is one that maybe will resonate with parents, new parents, but I think we all, I hope, have a variety of things that satisfy us, that excite us, a variety of ways to make contributions, and being able to balance those is important for everyone. And for me, pathology was thrilling, like I said, on the day-to-day and the long term, and also highly flexible. It is very rare that we have a true emergency that I couldn't drop at work if there was a true emergency at home. And that made things much more workable. So right after speaking with this woman, I was like, pathology. I loved histology. I loved my mouse model work. Right in the lab, I had spent full days at the microscope looking at mouse tumors. Yes, not human tumors, but very similar work, and loved those days. So that gave me the courage that this could be something that I enjoy every day and all day. So I started speaking with a bunch of people in our department, really, and honestly, and then their friends, right? So folks that did pathology here, and then folks that did pathology other places in the city and over the phone throughout the country, and started to learn about the field from an MD point of view, which I recognize it took so long for me to come around to pathology. My eyes were not perhaps as open as they could have been during medical school. This was the journey for me. I don't in any way regret the 3.5 years I got to operate. Those were amazing, amazing years. And I feel very lucky that I was able to pivot. So, right, I had conversations with surgical pathologists, cytopathologists, blood bankers, folks that used their MD and then pathology residency to work in a lab. And at that point, I wasn't confident what area of pathology was right, but I was confident that the field of pathology was right and I would find my way from there.
Yeah, it sounds like pathology became, or it sort of fulfilled all of the things that you liked about
Yeah.
just medical school and kind of science in general.
Agreed completely. And I think all the time I have a tight group of friends from med school,
Hmm.
phenomenal, amazing women. We all went into different fields. None of them started in pathology, none of them ended in pathology. I think all the time, had our medical school emphasized in the very beginning, hey, this histology class is taught by a PhD, but there are MDs that do this work. I wonder, would I have had alarm bells then? And I honestly think no. I think this was just journey I needed to go through. Longer than many, but there are people that come to medicine late also. So
Yeah, that's true. And one of the things, obviously, I'm not a doctor and never went to medical school, but one of the things I've noticed through the years that I've been doing this podcast and the people that I've interviewed is most of them, it's not a straight line. It's not like medical school. I know what specialty I want to get into, what subspecialty, all of that. And your story is an example of that too. I mean, you've got 3+ years in surgery, and then you pivot
right.
to what you really love.
It's funny. I think when I went to medical school, I very much thought that it was a straight line, right? Up to that point for me, it really had been, right? Go to high school, go to college, go to medical school, frankly, get married, which I did during medical school. And I saw that as part of that straight line that we're supposed to go through. I think now, though, on the other side, right, when I interview folks for residency, for fellowship, frankly, when I meet new people, some of the most interesting people had circuitous paths to where they are. And realize that at the time when my path turned, it was a source of anxiety and a feeling of what have I done wrong? Why couldn't I have figured this out more quickly? But I think that the interest you get on the journey is valuable. And the lessons I learned in surgery, some of them are really useful in pathology. When we started in the gross room, I was a resident with three amazing women who totally knew for a long time that they wanted to be pathologists. Their skills at the scope far superseded mine at the start of residency. In the gross room, I was much more comfortable, right? Of course, I can do a frozen on a Whipple. I've done a Whipple. I know where the margins are because I know where I would have cut on the other side. So, whatever skills you gain along the way, I think all skills end up being valuable.
Oh yeah, absolutely true. Absolutely true. Okay. Now you mentioned that you go into pathology and you weren't sure about subspecialties, but you chose cytopathology. How did that happen?
That's a good question. So, I immediately was drawn to work at the scope. I think that's the first step. Folks who are not super aware of what pathologists do don't necessarily realize we don't all make our living at a microscope, right? There are folks that run blood banks, that run chemistry labs, that may occasionally look at a microscope, but mostly don't. And then there are those of us who mostly spend our day at a microscope. I knew quickly I loved that. That made me very happy. I enjoyed that time. I felt satisfied by that time. For some people, once they learn, I want to spend my time in a microscope, they then pick an organ system, right? A lot of my colleagues said, I love the microscope and I love the gastrointestinal system, or I love the microscope and I think heat path is amazing. And that's great. I didn't necessarily want to specialize in that way. I liked the idea of getting to, in some ways, be a generalist and keep my fingers in different organ systems and not be required to To know everything about one, which your brains can only hold so much, is going to mean you're going to know less about others. For me, also, I think the exsurgent, the tactile aspect of performing SNAs was appealing. For better or worse, I think sometimes we as humans are drawn to things we feel more comfortable with or are better at. I, at that point, had operated for years, put in a million A lines. If I can put in an arterial line, I can put a tiny needle in a large nodule. So I quickly felt good about it. And that positive feedback makes you want to, or at least makes me want to do more. And I also enjoyed that aspect of patient interaction. Right. I think there are some pathologists who are very happy to not interact with patients, which is wonderful. We need those pathologists. There are some who enjoy the patient interaction, which, I'm one of those. Again, for me, it was the right patient interaction, right? Here I am. I'm going to tell you what I'm going to do. We're going to talk about it a little bit. I'm going to do it. I'm going to get you an answer. And then we're both going to move on. That's not the right level of interaction for everybody, but I recognize that for me, it's the right level. I felt useful. I felt that I was using my skills to help folks. And then I would do my next thing and the patient would do their next thing. So that was also appealing to me. This part might sound a little bit silly, but I'm like a rules girl. I'm drawn to rules. I think they help run our lives in a way, we all agree on these rules and that we all abide by these rules. So that lends itself to harmony. Cytology is an incredibly rules heavy part of pathology, which is already, I would say, a rules heavy profession.
Mm-hmm.
I was drawn to that. And I loved also sort of the categorizing associated, right? A lot of cytology is, do I put you in the benign category, in the atypical category, suspicious for malignancy or malignancy? And those categories have very strict meanings and strict, strict definitions and strict risks of malignancy. That the category itself is meaningful. I enjoyed that categorization. Not everybody does, right? Some folks want to, in surgical pathology, much more commonly, you're saying this is what it is. I liked in cytology that I was intervening earlier, but I didn't necessarily have to say what it is. Just saying the salivary gland has a high-grade malignancy in it is enough information for the patient to get the right next step of care. I don't have to necessarily be able to say yet what it is. There might not be enough material to definitively say, and that's okay. I sort of enjoyed that aspect, and I loved being part of the clinical team early on. Right? The patient arrives with this new lump in their face. Oh, we need cytology. We need them now, early. It made me still feel part of the treatment team, right? Like I was speaking before about how much I enjoyed the team aspect of the operating room. It felt like I was still on a team, which was a good feeling for me.
And this kind of goes back to you're making a difference in that patient's life at that particular moment.
Yeah, ideally, right? I'm the goal there is getting them to the next step of treatment, getting them to the appropriate care or reassuring them, right? This is just a benign
Yeah.
cyst. You don't need anything done. That's incredibly satisfying.
This is the People of Pathology podcast with our guest, Dr. Allison Goldberg. We'll be right back. LabVine's Laboratory Transformation Seasonal School is taking place virtually on September 3rd and 4th, 2024. This year's theme is Unlock the Power, utilizing new technologies to streamline workflows and improve performance. You'll earn 6 continuing education credits with topics like digital pathology, lab networks, and improving lab turnaround times. Oh yeah, and it's free. Go to labvinelearning.com and click on the events tab. It's the little calendar icon on the right side of the menu, or you can just follow the link in the show notes to register. If you think it would be nice to have a helpful reference about digital pathology, I have some great news for you. Dr. Alexander Zhurov has written a book called Digital Pathology 101. All you need to know to start and continue your digital pathology journey. This book will help you whether you're a complete novice or a digital pathology trailblazer. You can get a copy of it by following the link in the show notes. Now for the rest of my conversation with Dr. Allison Goldberg on the People of Pathology podcast. Now, you've been talking a little bit about FNAs, and this is cytopathology, it seems, has a bit of crossover with radiology because of FNA procedures. and
Yeah.
interventional radiology. And there are some emerging technologies kind of in this intersection of those two fields. Can you talk about this? Like, how are these technological advancements changing the field?
Yeah. So I think a lot to unpack there. First of all, right, the intersection between cytology and interventional radiology is one that is, I would say, ever changing. For our fellows, one of the things they are learning is ultrasound guided SNAs. They're never going to be ultrasonographers, but they'll use, our department has an ultrasound, they'll use that ultrasound to identify nodules so that they can obtain material from those nodules that we can then use to diagnose what those nodules are. There's going to be an ebb and flow, I think, forever between cytology and radiology for those lesions. We work very closely with our radiology colleagues, and we are appreciative of their incredible skill when it comes to using an ultrasound. And honestly, as not just ultrasound, but radiology in general is finding more and more smaller and smaller lesions. That's leading us to to perform biopsies or FNAs of more nodules, right? Think about thyroid as a good example, right? Folks have neck pain, end up getting an MRI or a CAT scan to evaluate the neck pain. Oh, we got the thyroid in too. Oh, there's a nodule that maybe it's not palpable, maybe it's not visible under the skin, but we're seeing it. Now you're going to end up following it or maybe doing an FNA of it and getting an answer of what it is. You didn't even know you had it. You went in for some other reason, right? These incidentalomas, for sure, we're seeing more of those. I think another advancement, another group we need to bring in on this team is our molecular pathologists. The more nodules we're performing fine needle aspirations on, some of them will be overtly benign. Great. Now we're just reassured. Some of them are going to be overtly malignant. And in some ways, great there also because now we know and we can take care of that malignancy. I think perhaps the most frustrating are the indeterminate categories, right? This is not overtly benign. This is not overtly malignant. There's a couple features that either are mild or rare. And so it becomes difficult to know the significance of those mild or rare features. And so molecular testing has really taken off, thyroid perhaps first, but certainly not last, taken off in terms of narrowing the category, that risk of malignancy, right? Whereas an atypical has a pretty wide range in terms of what's the risk of malignancy for an atypical nodule. If I'm telling you this is an atypical nodule with a KRAS mutation, well, now the chance of this being neoplastic, at least, is significantly higher. That's very valuable information. And you're going to have a different appropriate next step than if that nodule that we called atypical cytologically has no mutations. That's a new branch point that molecular is providing for us. Molecular is also sometimes helping us identify targetable mutations. So for example, lung, I think is a good example for that, right? We're gonna test for EGFR, and then there are medications that are gonna specifically target that mutation. 20 years ago, we weren't doing that. And so if you have a lung tumor with an EGFR mutation, that's very different than you have an adenocarcinoma. And I think that's another way that cytology is really very exciting because we've been on the forefront of that, right? How much information we can get out of such a teeny bit of material. This isn't even a biopsy. We're just talking cells, individual cells. But right, each of those cells, if they have this mutation, we will now find it and give you a different chemotherapy based on it.
That's interesting. Yeah, it does seem like cytology, cytopathology is on the forefront of the kind of molecular. I don't know if you want to call it revolution, but certainly an influence in pathology.
Absolutely. I mean, I think, right, we're not there yet, but we talk about how you don't have lung cancer, you have EGFR mutated cancer is going to be the path of the future, where your
Uh huh.
cancer is not based on your organ or necessarily even your cell type, but the actual mutation, right? We're not there yet. We don't know every single mutation, and we certainly don't have a drug that treats every single mutation,
Right.
but I think that's the hope.
Okay. Okay. That makes sense. And now you mentioned the fellows there where you work, and you're the director of the Cytopathology Fellowship. program. How did this happen? How'd you get this opportunity?
Yeah. So this is now my third, or current fellow is the third fellow that I've had the opportunity to be fellowship director for. I think, like many opportunities, right place, right time. I had been associate program director for our residency really since I became faculty. So for at this point, 6 years, 3-ish years ago, when the previous fellowship director left for a different opportunity, I think that made me sort of a reasonable candidate, right? I had experience in education, graduate medical education. I had experience in interviewing trainees, recruiting trainees, for better or worse, all of the paperwork that is required by the ACGME to keep a program accredited, right? None of this was going to be brand new to me, but I hadn't been in charge of a program before. So, I think the fact that I had some experience and some passion for it, right? I really enjoyed and enjoy my work as associate program director for the residency. I think allowed folks who were making the decision to be confident that it would be something that I would care about and want to put time and effort into, and also have some detail-oriented knowledge that I could rely on when it came time to keep our accreditation and to recruit new fellows and that sort of thing.
There's got to be a lot of rules involved with that too, which is kind of your thing, right?
Yeah, so it's funny. I think residency, yes, there are so
Okay.
many rules involved, right? The goal, of course, of any training program is to graduate a competent, for us, pathologist or cytopathologist who, for us, frankly, can sit for the boards and pass the boards. It's unfortunate that a test ends up being the final be all and end all, but there's got to be some gatekeeping to the profession, and we've landed on a test as the way to gatekeep. So part of it, of course, is we want to make sure you know what you need to know, both to be a good practicing pathologist and to pass the test that we've used as our gatekeeper to being a pathologist. So there are, yes, a number of rules involved in that. The fellowship, though, I would say is a lot more flexible than residency. Certainly there are still, right, ACGME has put out very clear milestones. This is where you belong, in terms of medical knowledge, in terms of systems-based practice. This is what we consider competent. So there are great guideposts. I appreciate, though, that there are not a ton of rules of how to get folks there, right? And we've partially, I think, because the pandemic changed education and allowed for let's say, a variety of experiences during the pandemic. We've had folks come for fellowship and residency with different backgrounds, whereas I think pre-pandemic, folks came in with a more uniform experience, especially folks graduating medical school and starting residency had a more uniform experience. I think the pandemic, everybody had to pivot education because of it. And the way those pivots were done were different in different places. And those pivots were differently successful for different people. So I think I am appreciative that there is a lot of flexibility in how we get folks where they need to be. And we've seen the need for that flexibility, let's say, over the last couple of years, more so than I noticed before.
So with people coming in with different backgrounds and different experiences and probably different goals, is what they're trying to get out of the fellowship, how do you tailor that to the individual fellow?
Yeah, that's a great question. And something I think about a lot, honestly, right? Because I recognize, so first of all, we have folks that are just over the 6 years or so I've been here. We have folks that were AP only that came to us. So they'd had really very little molecular experience, cytogenetics experience, even though that dovetails with a lot of the work we do. So those were folks that we wanted to emphasize those opportunities. We didn't need them to have the knowledge necessary to run a molecular lab, but they're going to have to review molecular reports. And we want them to feel very comfortable doing that. They're going to need to know the meaning beside certain mutations. We want them to have a high level of comfort with that. So that's a very different person. We've had folks that have come sort of that straight path, did med school, did APCP 4 years of training, and are now with us. We've also had folks that did APCP training, did a different fellowship, worked for a couple of years, and then realized they wanted either a different experience or a more broad experience. And so we, again, having the flexibility, right? We have the milestones, but where how we get folks there is up to us. So we've had folks spend more time up in molecular. We have a robust molecular lab here, more time up in molecular, more time with our faculty member who signs out cytology and molecular. So, she's an incredible resource. We've had folks that want to go into private practice. So they're finishing, a Cyto fellowship, but then they're going to have to go back to doing a bunch of surge paths, sort of a bunch of everything at the scope. So we make sure second half of the year, we're getting, everybody's biopsies, all the other faculty members after they sign out their biopsies, please drop them off at our fellow's door. She's going to look through them overnight and she's going to come to you if she has any questions on them. You know, Incredibly grateful. Our faculty are thrilled to teach in whatever capacity it is. So getting those experiences for folks, just sort of helping them remember some of their surge path knowledge or heme path knowledge that they haven't been using those muscles as intensely over the year. Very helpful. And we have folks who want to go into academic practice, right? Want to do what I'm doing. And so that's a different set of muscles we have to help them flex. We encourage all of our fellows to certainly engage with the literature. You can't be a good pathologist unless you're willing to be a lifelong learner, lifelong reader of the literature. So that's a must for everyone. But for folks that are interested in an academic career, they have to get comfortable also creating the literature. So we encourage all of our fellows to submit abstracts to USCAP, to ASC. Those are probably the two most popular meetings, but if there's another meeting for a good reason, absolutely, we're all very happy to support that, both in terms of time and money. We also have had, I would say, great success of getting our fellows that are interested in academics, getting them publications during their fellowship year. There's something really valuable about pressing that submit button when you still have a faculty member right behind your shoulder, getting that experience out of the way. You don't want to do anything for the first time when you're on faculty. So for folks, for everybody, but even more so folks interested in going into academia, it's important to have submitted for publication, submitted revisions for publication before you're the one in charge. So we make sure we have those opportunities for everyone, but for anybody who's considering academia, we work really hard to make sure those opportunities are robust.
Okay, I like that. That sounds like a lot of different options depending on the person's personality, goals, all of those things we mentioned. Something else we've talked a few times now about the effect of molecular testing on cytopathology. What about AI? Is that having an effect, or do you think it's going to have an effect?
Yeah, AI in pathology is certainly a hot topic. That was like the topic at the cytology meeting last November, and I'm sure will be hot again this November. I think when we talk about AI, it's two little letters that have a ton of meaning behind them. And there's a lot of different ways to think about AI in pathology in general and cytopathology specifically. I do not think computers are replacing me in my lifetime. I think that's really important for everyone to hear. I don't think anybody should say, I would consider pathology, but a computer is going to be doing that, and so I shouldn't. No, I will have a job. I'm not worried. I think there are certain things that algorithms, let's say, can do very well, particularly jobs that maybe I don't enjoy very much. So sort of needle in a haystack type work, right? I'm looking for these single aspergillus in this entire slide, which would drastically change what's going to happen for this patient. That is work that I would welcome an algorithm for, right? That is work that I recognize a computer is better than me. I will do my absolute best. I will go slow. I will go on high power. I know exactly what aspergillus looks like, but a computer is better at that work than me. I know a computer is also better at estimating. So for certain diagnoses, it matters a lot. Are 3% of the nuclei positive or are 1% of the nuclei positive? That could be a big difference.
Yeah.
I am not as good as a computer, right? That's something where, again, a computer is excellent, assuming the algorithm is excellent. With the right algorithm, a computer is very good at that work. So Those are things I am just very happy to cede to an algorithm. Algorithms also have long been used in cytology to find, let's say, the most worrisome fields. So we do computer assisted, we don't, but many institutions will use computer assist for screening pap smears. Computer will say, right, these are the 20 some most worrisome fields of view. If you look through those fields of view and they are all benign, you can reliably say this pap smear is benign. Great, right? That you just drastically decreased my work. Wonderful. I'm all for that. But we've been working for a while and are still nowhere near the computer saying, these are the most worrisome field and they're a low-grade squamous intraepithelial lesion, right? They can find the worst spot, but they can't necessarily tell you what it is in that worst spot. So I still have a job, right? Thank goodness. And I get to do the fun part of the job, which is not the finding of the cells, but the assessing of those cells themselves. So, right, I think those are areas where AI is already prime time or will be shortly, or at least computer assist, let's say, is already prime time or will be shortly. I think things like machine learning, deep learning, it's coming. I think that's going to be much more slow and is best suited, at least at first, to answer binary questions, right? Does this pap smear have trichomonas on it? Yes or no? And hey, computer, here's a gazillion images of trichomonas and how it can look, right? I could see that being ceded to a computer at some point, but to say instead, here's a sea of cells from someone's urine, what is the diagnosis? Is a much more complex question than are there any trichomonas in this urine? And so that's why I feel confident that I will have a job because AI is nowhere near handling those complex questions. But I'm good with AI maybe doing some of the jobs that are easier for a computer or better suited for a computer than a human brain. I will say, I have some fear of sort of the black box AI, right? The startup company with private capital behind it saying, I will give you a diagnosis, but I won't tell you how or where it came from. I have concerns there because holy cow, we need regulations, right? I have to do proficiency testing on a regular basis to make sure that my diagnoses stay up to snuff with the literature, right? What we call something today, 5 years from now, we might call differently. I do not feel comfortable ceding that to a black box that I have no knowledge of, that doesn't have to do proficiency testing, doesn't have to prove that it's not undergoing drift in some way, that it is no longer as accurate as it once was. So that freaks me out.
Okay, that makes so AI with some oversight is good.
Correct.
Okay.
Right. I think we need real guardrails and radiology, I think, is going through similar learning curve, let's say. But like I'm not as familiar with the radiology regulations. The regulations to be accredited, to have an accredited lab in pathology are robust and on purpose and for good reason. If we're going to tell somebody this is what you have, and then you're going to get treatment based on that, we darn well better be right. And I don't trust that to a black box.
Okay, that makes sense. One thing I wanted to talk about with you is the aspect of leadership roles in medicine, in pathology in general. Do you think it's important for pathologists to have leadership roles?
So I loved this question.
Okay.
And so part of it, I think, is how do you define leadership?
Mhm.
So I'm going to put a pin in that for a second. I think it is critical for pathologists to fight to be in the room for all rooms in the medical field, right? Our work ends up making up so much of the medical record, and our work is what most treatment is based on, what most patients' treatment is based on. And so do I need to run the room? I don't think I do. There may be others who feel that we should be running the room and agree to disagree. I think the critical thing for pathologists is we need to be in the room. It is easy to overlook, like I did, us as healthcare professionals, it is easy to think of us as almost machines, right? You take a drop of blood and you put it in a machine and the answer comes out and there's no thought behind it. And that is underinformed, let's say. So, right, I think it is critical that we're in the room to have a voice for the lab, but also so that we can advocate for patient care, right? I think we need to be part of the conversation of what is the right test at the right time for this patient. Those are not decisions that we should be ceding to the clinicians at the bedside. So I think that's number one, why we need to be in the room. I think also when it comes to sort of medicine as a whole, we again are going to be providing the information on which decisions are made for the most part. And so again, we need to be in the room, right? When we're creating an electronic health record, we need to be in the room so we can comment on how results should be seen so that they can be, how am I describing this? Well, I don't want somebody to have to search for what the meat of my result is, right? I want that to be easy for them to find, which can be challenging when we could be putting together a lot of information, right? A thyroid nodule is a good example. I'm going to start maybe by saying this is an atypical thyroid nodule and here's why. And then a week later, you're going to get a molecular result also. Ideally, it should be easy for the reader to find both of those results together, because together it's how they're going to make an informed decision for patient care. Also, frankly, we have, based on all of our regulations, we need an electronic health record that is going to allow us to easily do things like cytology, histology, correlation, right? I'm required for anything where I have a cytology result and then later there's a resection based on it. I'm required to review, do those match or do they not? Certain electronic health records make it very easy to follow what histology follows a cytology. Certain make it much more challenging. And again, if we are in the room, we can point out these areas for improvement, let's say. Thinking also consolidation is happening, I think, in hospitals all around the country. How do you consolidate the lab? I don't want someone else telling me how to consolidate the lab, right? I want laboratorians to be saying, oh, we need couriers more frequently if that specimen sits out overnight, 100 miles away. Well, I can't send it to flow in the morning. Those cells are dead. If you're going to ship blood products, how do you handle doing that across state lines, right? Again, we need a laboratorian who's explaining why what plan might not work. Or here's a way that would be cheaper or more efficient or improve turnaround time. So that's, another area where, again, I don't need to run the show for consolidation, but I think pathologists, laboratorians need to be involved in those decisions.
100% agree with that. Yeah, that's been kind of a common theme as well throughout this podcast is that pathologists especially, but like you're saying, all laboratorians should have a say in what's being in the decisions that are made about what they're doing. Because, they have the best knowledge, the best idea of what they need.
Right. And I will say, and I'm sure this is also not unique to us, but workforce shortages have hit us significantly. And the decision of how to manage those workforce shortages, people can only do so much. So do you send out certain tests that are incredibly time intensive? Do you switch to other tests which maybe have some downfalls, but they're easier to perform? Do you just accept that you're going to have a longer turnaround time? Right? These are all ways to manage workforce shortages. And again, I want laboratorians, I want people who understand the laboratory to be the ones deciding how we're going to do that.
Yeah. I love that. The last question, then we talked about molecular testing. We talked a little bit about AI. What do you think is going to be the next kind of big thing in pathology?
So I found this question very challenging also. I think true personal medicine might be the next big thing, right? Like how I said previously, not just here's your tumor, here's the molecular alterations it has, but right, not lung cancer, EGFR mutated cancer. I think we're in the midst of that. We're maybe even in the baby stages of that. But I think that is something where pathology is headed. So I don't know if it's the next big thing or if it's the boom is coming and we're not quite in the boom yet. I think that is the potential to just completely alter how we treat patients. So incredibly exciting. Something else which we really already touched on, feeding certain work to the computer, I think will come. It's not there yet, but I think it will come. Work like I'm looking for a single fungal element in a bronchoalveolar lavage. That's work that a computer is going to be better than me. So I think those two areas we're working towards and we'll be here eventually, perhaps in my lifetime, probably my lifetime. Not sure if they'll be robust in my work lifetime, let's say, hoping that there's life after work life. And in terms of preparing for it, I think pathologists in general, laboratorians in general, need to be lifelong learners, need to be curious forever. I think whenever the next big thing is, being curious every day, being honest about what you don't know, as long as that's being coupled with being excited to learn about it, is going to be critical for whatever comes next. It's something I certainly try to instill in all of our trainees, try to instill on myself, being honest where the edge of my knowledge is, as long as and that's okay. Everyone has an edge to their knowledge, as long as you are excited about pushing that edge. And when patient care is involved, as long as you are comfortable where the edge is and then actively seeking out the person whose edge is a little further, so we can get the right answer, or whether it's in the literature, whether it's the office next door. I think being persistently curious, whatever comes next, will prepare laboratorians for it.
Yeah, I love that. And I definitely agree. Dr. Goldberg, this has been a fascinating conversation. I appreciate you sharing your story and your thoughts on what's happening in cytopathology now and in the future with us. So, Dr. Allison Goldberg, thank you very much.
Thank you so much. This was a pleasure.
If you're looking for another episode of the People of Pathology podcast to check out after this one, here's a clip from my interview with Dr. Amanda Herman as we talk about improving the fellowship application process.
And at their first meeting, they were talking about fellowships. And they were like, well, people are complaining. And I was like, well, I can tell you my experience, because at the time, I was a second-year resident, about to be a third-year resident, and like, this is when I'm supposed to be applying for fellowship. I feel completely not unprepared, but I really don't want to make this decision right now. I'm only halfway through residency. I have not seen everything. How do I know that I don't want to be a pediatric pathologist? I'm not going to see pediatric pathology till my fourth year. Maybe this is another one of those missed opportunities that, I'm just not ready to make that decision right now. And I told that to them at the meeting. I said, this is how we're feeling right now. I'm a representative resident. I'm here to tell you, we hate that we have to decide so early.
You can hear more from Dr. Amanda Herman in episode 136. All right, great big thanks to Dr. Allison Goldberg. Pathologists play a crucial role in the healthcare decision-making process, advocating for patient care and assuring accurate diagnoses. You and I know this. In this episode, Dr. Goldberg emphasized the importance of pathologists being present in various settings to have a voice for the laboratory. She highlighted the need for pathologists to be involved in discussions about appropriate tests, as their work forms the basis for most treatment decisions. She also emphasized the importance of pathologists being present when decisions are being made about consolidating labs, managing workforce shortages, and implementing new technologies like AI and molecular testing. We discussed the evolving landscape of personalized medicine in pathology, where diagnoses are becoming more specific based on molecular alterations rather than general tumor types. This shift towards personalized medicine underscores the importance of pathologists actively participating in decision-making processes to ensure that patients receive tailored and accurate treatment plans. We also explored her specialization in cytopathology, where she found a perfect blend of microscope work, patient interaction, and the satisfaction of making impactful diagnoses. Her enthusiasm for the field was obvious as she discussed the evolving intersection of cytopathology with radiology and molecular pathology. You could hear in her voice how excited she was by these developments. As the director of the Cytopathology Fellowship program, she shared insights into her role and the importance of tailoring training to individual fellows' backgrounds and career goals. Her commitment to education and mentorship was clear as she discussed the flexibility and support provided to fellows to help them achieve their career goals. Dr. Goldberg's insights on the future of pathology highlight the need for continuous learning and curiosity among pathologists to adapt to upcoming changes. And again, you could hear how these coming changes stimulate her own curiosity. Having that kind of excitement about your field is something all of us can strive for. As always, I'll have links in the show notes to everything that we talked about today. Don't forget, you can follow the show on Twitter and Instagram. I'm at People of Path, or just connect with me on LinkedIn. Thank you for continuing to share the show with others. Together, let's inspire the next generation of pathologists and laboratory professionals. This show is a member of Health Podcast Network. Thank you for listening. I'm Dennis Strank, and I'll talk to you next time on the People at Pathology podcast.